as a researcher for a long time, and her research interests include psychotherapies, depression, euthymia, which she'll be talking to us today about, allostatic load, and importantly, clinimetric, something we could all stand to learn a lot more about. Made famous by the Yale professor Alvin Friedman. And she's the author and co-author of more than 80 articles published in high-impact journals. And she's been a key collaborator of Professor Giovanni Fava over the years, publishing important papers on allostasis and allostatic load. I still remember a wonderful paper that they did with the late Bruce McEwen, actually moving from a lab description of allostatic load to the bedside, a really important contribution. And they've also published on today's topic, which is the concept of euthymia. So with that, Jenny, thanks again for being with us. And I should mention that if you have questions, you can feel free to put them in the chat. And Darshan will be looking over the question and answers at the end. And we should have 10 or 15 minutes for questions at the end. So, Jenny, thanks again for doing this for us. And we look forward to your talk.
Thank you, Greg, for your kind introduction. And today I will cover some conceptual issues related to euthymia and other clinical constructs, and its clinimetric measurement, and also I will discuss some clinical applications. Here is my disclosure, and as to the conceptual issues, I think it's important to start from a general consideration. The term euthymia has a Greek origin and results from the combination of eu, well, and thymos, soul. And this latter element actually encompasses different meanings such as life, energy, feelings, will, desire, but also thought and intelligence. And the original definition of euthymia is generally ascribed to Democritus, a Greek philosopher, that defined euthymia as a state of quiet satisfaction and balance of emotions. Then the Latin philosopher Seneca translated the Greek term euthymia by tranquillitas animi, a state of internal calm and contentment that requires the awareness of well-being. Then Plutarch, who attempted a synthesis of both Greek and Latin cultures, criticized the concept of euthymia as defined by Epicurus as detachment from current events, and underscored the learning potential of adverse life situations and mood alterations. In the psychiatric literature, the term euthymia generally connotes the lack of mood disturbances meeting the threshold for a mental disorder, as assessed by either diagnostic criteria or cutoff points on dimensional rating scales. But we know that in bipolar disorders, considerable fluctuations in psychological distress may occur over time, suggesting that the illness is still active during the so-called euthymic periods, even though its intensity may vary. And similar considerations apply also to unipolar major depressive disorder and persistent depressive disorder. Indeed, residual symptoms were found to be exceedingly common in both bipolar and unipolar mood disorders. And so euthymia was defined essentially in negative terms and not at the presence of specific positive features. In 1958, Mary Yahoda published an extremely important book entitled Current Concepts of Positive Mental Health, where she argued that we cannot define positive mental health merely as the absence of mental disease, but it would seem to be more fruitful to tackle the concept of mental health in its more positive connotation. And based on a careful inspection of the available literature, she identified 6 major categories of concepts and outlined 6 criteria for positive mental health. Namely, autonomy, that is regulation of behavior from within according to personal standards and resisting to social pressures. Environmental mastery, a key element in facing stressful life experiences, leading to a sense of competence in managing the environment, capacity for adaptation and adjustment, efficiency in problem solving, and adequacy in work, pleasurable time, love, and interpersonal relationships. Then perception of reality, leading to satisfactory interactions with other people and the environment. And the individual's degree of growth, leading to a sense of continued development and improvement, that is personal growth, and purpose in life, setting personal goals, feeling there is a meaning to present and past life. And also positive attitudes toward oneself, leading to self-acceptance and satisfaction. But there is more. Maria Oda outlined a characteristic that is very important and is very much related to the concept of euthymia. And she defined it as balance and integration of psychic forces, leading to flexibility, consistency, and resistance to stress. And in 2016, Professors Fava and Beck provided a novel definition of euthymia according to specific clinimetric criteria, as characterized by lack of mood disturbances that can be subsumed under diagnostic rubrics, and if the person has a prior history of mood disorder, he or she should be in full remission. And if sadness, anxiety, or irritability are experienced by the person, they tend to be short-lived and related to specific situations. And in Yaoda's words, these symptoms can seriously unbalance the degree of integration an individual has achieved. Presence of positive affect, such as feeling cheerful, calm, active, interested in things, and rested. And balance levels in psychological well-being dimensions, leading to flexibility, consistency, and resilience. The concept of euthymia was subsequently refined by Professor Giovanni Favendai and further elaborated as a unitary concept according to the clinimetric perspective, with particular regard to its relationship with other clinical constructs. According to this framework, the unifying concept of euthymia is articulated in heterogeneous components, and particularly the psychological well-being dimensions have a bipolar nature, ranging from suboptimal to excessively elevated levels, and interact with each other through a compensatory or dysfunctional dynamic balance. Further, euthymia is intertwined with the individual's characteristics, concurrent distress, and other psychological attributes. And there is a complex balance between euthymia and dysthymia. Euthymia can be conceptualized at the other end of a continuum with dysthymia. And even though the term dysthymia is basically regarded as a synonym of chronic depressive disorder, its original definition provides the conceptual ground for a continuum between euthymia and dysthymia. Dysthymia does not fall within specific DSM-5 categories here, and is characterized by the presence of demoralization and subjective incompetence, chronic worrying, mental pain, rigidity, and abnormal reactivity to social environment. And between euthymia and dysthymia, there is an intermediate area that is called discomfort, characterized by the lack of positive affect and imbalanced levels in well-being dimensions. And again, this is unlikely to fit current diagnostic categories as well. Despite the recognized importance of lifestyle modifications in clinical medicine, the presence of psychological distress and unbalanced levels of psychological well-being represent major obstacles to behavioral change. And there is also growing awareness of the role of allostatic load and overload, the cumulative effects of daily life experiences, including both major life events and chronic stress, and possibly exceeding the individual's coping resources and resulting in allostatic overload on both physical and mental health. And here you can find a systematic review that we published a few years ago when we pointed out that allostatic load and overload are associated with poorer health outcomes. The conceptual framework of allostatic load also includes the physiological consequences of the resulting health-damaging behaviors, such as physical inactivity, unhealthy eating habits, poor sleep, smoking, and alcohol and drug consumption. And according to this model, allostatic load and lifestyle behaviors all interact with each other and contribute in turn to the dynamic balance between euthymia and dysthymia. And in McKeon's words, euthymia means using allostasis optimally and maintaining a healthy balance that promotes positive aspects of brain and body health through health-promoting behaviors. And according to clinical evidence, we argued that enduring lifestyle changes can only be achieved with a personalized approach that targets euthymia, such as well-being therapy. And here are some examples of randomized controlled trials in which well-being therapy was administered in order to improve lifestyle and clinical outcomes in patients with acute coronary syndromes, type 2 diabetes, obesity, and sleep disorders. As the clinimetric measurement of euthymia and other clinical constructs, we know that exclusive reliance on diagnostic criteria does not reflect the complex situations that are often encountered in clinical practice. Therefore, we should refer to clinimetrics, the science of clinical measurement, as a domain concerned with rating scales, indexes, and other expressions to describe and measure symptoms, physical signs, and other clinical phenomena that do not find room in the customary taxonomy. And according to clinimetrics, the diagnostic process needs to be integrated with an expanded clinical interview encompassing evaluation of euthymia and dysthymia, allostatic load and overload, and lifestyle according to a longitudinal perspective. And the clinimetric integration of diagnostic criteria actually requires building unitary concepts, thus providing broad global ratings of clinical phenomena, expanding assessment of comorbidity, using staging methods to describe the longitudinal development of symptoms and medical and mental disorders, differentiating symptoms according to their intensity, duration, trajectory, and individual impact on patients' life, using repeated assessment to monitor changes over time, and functional assessment strategies such as macro and microanalysis to guide treatment planning. Both observer-rated and self-rated tools were developed according to clinimetric principles for assessing euthymia and other related clinical constructs. In particular, the clinical interview for euthymia is a 22-item observer-rated tool covering the domain of positive affect, both impaired and excessive levels in well-being dimensions, and flexibility, consistency, and resilience. And it is concerned with the general attitudes of the patient. The first 5 items were derived from the WHO-5 Wellbeing Index and refer to feeling cheerful, calm, active, interested in things, and rested. Items 6 to 17 allow to assess both polarities of each of the 6 psychological well-being dimensions developed by Mary Yahoda. And the yes-no format has been chosen to increase the sensitivity of the interview that can be used as an index of change. The total score may range from 0 to 22, with higher scores indicating higher levels of euthymia. And there are also reverse items that are underscored here in the slides. So you can see there is a couple of items for each dimension, such as environmental mastery, personal growth, purpose in life and autonomy, and self-acceptance and positive relations with others. And the last 5 items allow to assess the domains of flexibility, consistency, and resilience. The euthymia scale is a self-rated questionnaire and basically represent an expanded version of the WHO-5 Wellbeing Index, including flexibility, consistency, and resistance to stress, in addition to positive affect. There are no reverse items here, and the total score may range from 0 to 10. As to other related clinical constructs, the clinical interview for dysthymia is a 17-item semi-structured interview encompassing the domains of demoralization and subjective incompetence, chronic worrying, mental pain, rigidity, and abnormal reactivity to the environment. It is also concerned with the general attitudes of the patient, and the total score may range from 0 to 17. Individual diagnostic modules derived from the semi-structured interview based on the DCPR, the diagnostic criteria for psychosomatic research, can also be administered to assess clinical constructs such as allostatic overload and demoralization. The DCPR were originally developed in 1995 by an international group of clinical investigators and subsequently revised in 2017. They were widely applied in different medical settings to identify subclinical and psychosomatic syndromes that could not be detected using traditional psychiatric diagnostic systems. And specific criteria were developed for determining the presence of allostatic overload as the presence of a current identifiable source of distress in the form of recent life event and or chronic stress exceeding the individual coping resources. And stress is associated with one or more of the following features, at least 2 symptoms, including psychiatric and psychosomatic symptoms, a significant impairment in social or occupational functioning, and impairment in environmental mastery. that is feeling overwhelmed by the demands of everyday life. And according to this criteria, we developed the diagnostic module for allostatic overload, and both A and B criteria should be satisfied. Specific criteria were also developed for demoralization as a feeling state characterized by the patient's perception of being unable to cope with some pressing problems and or lack of adequate support from others, that is helplessness, while the individual maintains the capacity to react. And the presence of hopelessness here has been regarded as a specifier and a marker of severity. And according to this definition, we developed the diagnostic module for demoralization and covering the criteria A and B, and demoralization with hopelessness with the criterion C as a marker of severity. A dimensional observer rated to assess the degree of severity of demoralization symptoms was also recently developed, namely the clinical interview for demoralization. And this interview encompasses the key domains of demoralization in line with the ICD-11 definition, namely subjective incompetence and inability to cope, discouragement, helplessness, and hopelessness. The response format here is based on a 7-point Likert type scale with specific definition of each anchor point. The interview is concerned with the past week, and the total score may range from 4 to 28. And here is some recent publications related to the clinical characterization of demoralization, its differential diagnosis from depression, with particular reference to oncology and medical settings. So moving to clinical applications of the concept of euthymia, well-being therapy as a psychotherapeutic strategy specifically aimed at modulating psychological well-being and pursuing a state of euthymia. And well-being therapy has introduced a clinical revolution in self-observation, since patients here are encouraged to identify episodes of well-being instead of distress and to set them into a situational context. Well-being therapy has been manualized in 2016 by Professor Giovanni Fava and validated in a number of randomized controlled trials, and specific training is provided by the Academy of Well-being Therapy. We may define well-being therapy as a structured, directed, problem-oriented technique that extends over 8 to 16 sessions, and the number of sessions can be abridged if it is preceded by CBT. Indeed, the well-being therapy can be administered sequentially after CBT. And again, the focus is on self-observation of well-being with the use of a structured diary and homework assignments for promoting optimal experiences. And here are a couple of review articles that we published focusing on the emerging role of euthymia in psychotherapy research and practice and conceptual and clinical innovations of well-being therapy. Just to be clear, in cognitive therapy, we ask patients to monitor situations leading to distress through negative automatic thoughts. In well-being therapy, we ask patients to report in a structured diary instances of well-being and feelings of well-being and their intensity, and then to identify the interfering thoughts or behaviors that interrupt this well-being and then lead to distress. The initial sessions of well-being therapy are focused on self-monitoring of episodes of well-being and promoting optimal experiences. Then the intermediate sessions are concerned with identification of thoughts and beliefs leading to premature interruption of well-being. Then the final sessions are concerned with discussion and modification of dysfunctional beliefs according to the most unbalanced well-being dimensions in the individual clinical case. Here is an example of the structured diary that we use in well-being therapy. So as you can see, there is a column for the well-being episode, well-being feelings and intensity from 0 to 100, and then the interfering thoughts and behaviors. And of course, we use cognitive restructuring through the observers column. And it's important to remind that both low levels and excessively elevated levels in the dimensions of psychological well-being can be detrimental for mental health. So we try to help patients reach a balanced functional level in each dimension, and with particular regard to the most imbalanced in the particular case. And here you can see the 3 different levels for each dimension of well-being according to our multidimensional model. Over the years, clinical evidence has shown the efficacy of well-being therapy for relapse prevention and increasing also the level of recovery in affective disorders and modulating mood. Well-being therapy was also effective in improving medical outcomes through lifestyle modification in a variety of medical settings. And we also use well-being therapy and tested well-being therapy in school settings for educational purposes. But there are many emerging areas of application of well-being therapy, including chronic pain, such as migraine and fibromyalgia, post-traumatic stress disorder and feeding and eating disorders, and in overcoming treatment resistance and discontinuing psychotropic drugs, with particular reference to antidepressant drugs, as outlined in the recent book by Professor Fava, Discontinuing Antidepressant Drugs. And we also recently highlight the role of well-being therapy in managing burnout syndrome, with particular regard to medical workers. This is a recent publication in which well-being therapy was administered online and was found to be helpful and effective in overcoming allostatic overload in medical workers during the COVID-19 pandemic. And in this editorial, we discussed the role of euthymia and other related constructs in the evaluation and treatment of burnout in medical workers. So to conclude, euthymia represents a transdiagnostic unifying concept. Its clinical relevance may support innovative approaches to the assessment and treatment of mental disorders, with particular reference to decreasing vulnerability to relapse and increasing the level of recovery in affective disorders and modulating mood. But the use of psychotherapeutic strategies aimed at promoting euthymia should always follow clinical reasoning and case formulation according to a clinimetric approach. Indeed, the treatment plan should be filtered by clinical judgment, taking into consideration and integrating a number of clinical variables, such as the characteristics and severity of the psychiatric episode, co-occurring symptoms and problems, and not necessarily syndromes, medical comorbidities, patient's treatment history, and levels of psychological well-being. And I would really like to thank you for your attention. Here are my email addresses. So you can just use both of them in case you need. And for those who are interested, we also have an official website for the Academy of Wellbeing Therapy, when you can find more detailed information regarding this approach, the manual, the courses, and the relevant literature. Thank you so much.
Thank you. Well, that was really wonderful, Jenny. You, I'm sure, provoked a lot of thinking in our group of attendees. And we will open it up for questions. But as moderator, I do have a couple of thoughts. First of all, I'm so impressed with how you have used clinimetrics really to operationalize these concepts of the human experience. It's really quite impressive. And, you know, I know you now living in Cambridge. Cambridge is the home of William James. And of course, the conversation with you today reminds us of his juxtaposing the healthy-minded among us with the sick souls among us in the varieties of religious experience. But William James never really went on to operationalize those concepts and to develop bedside bedside tools to try to help us understand them. So I think that to me is a really important contribution that you are making. The other association I have is, you know, here at Harvard, we have a wonderful epidemiologist by the name of Tyler Vanderweel. Many of the people in the audience know Tyler, and Tyler has gotten a huge grant along with Byron Johnson at Baylor to study human flourishing. And I think he has a six-dimension view of human flourishing that they're studying all around the world. So it would be good now that you're here at MGH and I'll be happy to introduce you to Tyler and to Matt Lee, his associate, because I think there are intersections with what
Oh,
you're studying. Yes.
yeah, there could be some overlaps and things that we may share, and also differences. And I think that it could be very helpful also to discuss and share different perspectives. So I'm totally in.
Yeah, that's great. The one little question I have is, I mean, I like the continuum of dysthymia and discomfort and euthymia, but in your work, have you been running into hyperthymia, sort of like the far end of the continuum, where there are people who are so enthusiastic about living that they are kind of euphoric a lot of the time and elated. Have you run into those sorts of folks?
Well, so in our model, we did not consider hyperthermia, but of course, we are aware of the fact that there might be people with this kind of temperament, I would say,
Yeah. Yeah.
and could be a kind of another end of the continuum in
Right.
some way. Even though we should be aware of the fact that excessively high levels in some aspects could be risky or detrimental at some point. So we should be very careful in evaluating also hyperthymic temperament and so on.
Very good. Very good. Okay, Darshan.
Yeah. Well, so I guess one of the questions, Dr. John Matthews, I don't know if you want to, you can just unmute and just ask your question. Yes.
I can just ask it. So, there's a beautiful presentation. I really believe in a functional approach to psychiatric interventions and assessment rather than just going through items of symptoms and so forth. So I think this is also consistent with my interest in acceptance and commitment therapy, which takes a functional approach. And based, living your life out through your values, I think that's really important. And this is very consistent with that kind of an approach. And I enjoy what you presented very much. I had just a couple other quick questions. Have you noticed that, have you studied this approach with patients with comorbid conditions, say medical and psychiatric conditions, and see that both are improved? Um, um,
Yeah, for example, in the study that we ran in cardiology, they were patients with acute coronary syndrome and comorbid depressive disorder and or demoralization.
yes,
And they improved in the psychological dimensional outcome measures, but also in some medical outcome too. So it seems like that also through lifestyle modifications, we might improve also the medical outcome of patients with comorbid psychiatric disorders.
yes, and I think that one of the mechanisms that has been um, uh, discussed and researched is the impact of psychotherapy interventions on inflammation, and that maybe this is why I don't know if you've studied the impact on inflammation biomarkers or anything like that with this approach.
I'm not sure that they were specifically investigated, but we definitely have studies in which medical outcomes improved after Wellbeing therapy. So,
Yeah, because one of the presumed mechanisms is that if you improve inflammation, both comorbid conditions will improve because
yeah, I mean,
inflammation plays a role in both.
there might be a positive interaction between all these factors. So,
Yeah, sure.
yeah, thank you. Thank you so much.
Mahmuda, did you want to answer your question?
Yes, thank you. This is wonderful. Uh, I know some of us are coaches here, and the well-being based therapy is resonates a lot. My question was about hyperthymia. Is that, I'm not a psychiatrist, so is that related to mania?
I mean, the detrimental course of hyperthermia could end out with hypomanic features, I guess. This is my perspective. But we definitely are not so much focused on hyperthermia. So it's something that actually came out during this discussion, but is not a specific focus on our clinical investigation.
Thank you.
So, Jenny, I had a question just to think about
Yeah.
more from a global construct. So, do you feel this notion, the construct of well-being, you know, it's a very, I think oftentimes we think of well-being from a very European or centric perspective, whereas perhaps in some of the Asian constructs, there's sort of notion of decrease of suffering. How do you see the two do you feel like this construct is applicable in a global way, or is it because language matters, it turns out, right, in this? And are there is the language here applicable globally, or you think it's really in a particular construct or context, I should say, context?
Yes. So there might be cultural factors, but I was just thinking about the fact that a number of studies were run also in in China or in the Eastern countries. So I was just thinking about the fact that there might be a room for well-being therapy also among other cultures. And actually, well-being therapy seems to work well in China and other countries. So it's not definitely just based on our own culture. So I think that there might be some applicability also in other cultures. But we definitely need to study if there are cultural variables that might influence the view of well-being across cultures.
Thank you. Other questions? Feel free to unmute. Oh, Peg, are you
Okay, so
Peg?
I also,
Oh.
Sorry.
Yeah, go ahead, Peg. Yeah.
Oh, I love your presentation. I feel better just having listened to your presentation. So thank you for that. In our program, and I just finished one of our classes on cultivating humor as a fundamental coping strategy, and the cognitive work that's in the well-being that I think is challenging from one culture to another is this sense of humor. Is humor and laughter part of overall well-being? Is it one of the indices and focus of the intervention?
Oh, well, I think that if the levels of self-acceptance in a person are impaired, there might be difficulties in using humor or also self-ironic instances, I mean, as a way of overcoming some weaknesses or for accepting own self. So there might be some connection between some dimension of well-being and humor as a coping strategy, I would say.
Thank you.
I know that humor is also part of, an ingredient within a 3RP program. So I was just curious and interested in knowing more about your protocols and so on. So we're gonna have further occasions, I guess, to discuss further these issues.
For sure.
Jenny, I really enjoyed how you started off by helping us learn about the Greek origins
Yeah.
of euthymia. And it made me think of another Greek word. I think Homer was the first one to use it, was acedia, which is listlessness and apathy and almost like a disappearance of affect. And it's funny when you think about that concept, it became a religious one. In fact, in the monasteries in medieval Europe, the monks who started to show this listlessness and apathy, it became something which the abbot would say was sinful, and they have to try to overcome that. And I'm wondering, on your continuum, dysthymia, euthymia, this dysthymia, discomfort, and euthymia, where would you think acedia fits in? That kind of sense of listlessness and apathy, and almost like a loss of affect.
Oh, well, I'm not sure I could understand exactly the word that you said. That was
It's
the
acedia.
Greek word.
It's acedia, and
Okay, I see. Maybe, there are some imbalances in the dimensions of personal growth, for example, when a person feel like a sense of stagnation and no opportunities. He or she is not like to accept new opportunities to personal growth or deep development. That could be kind of acidia, you know,
Yeah.
because you feel like you're not interested in improving yourself or taking advantage of opportunities, and you just this kind of stagnation, possibly leading to dissatisfaction as well.
Yeah. It's a good word for it, stagnation. Good. Thank you.
Greg mentioned Tyler Vanderweel's work on human flourishing. I think one of the dimensions he looks at is meaning and purpose. I wonder how you fit that into your conception of demoralization and well-being therapies.
Yeah, well, we in our clinical experience, we actually saw that when you are working on some dimensions, well-being, such as, for example, purpose in life or personal growth, also, you may have an impact on demoralization without specific psychotherapeutic work on demoralization, because these aspects are all related. So if the person, for example, has a low purpose in life, low personal growth, and maybe excessively elevated standards, unrealistic standards, this combination may lead to demoralization, and working on well-being, you may also have an impact on demoralization too.
Thank
Yeah,
you.
according to to ACT, that meaning and purpose is derived from engagement in values-based actions, behaviors, and some determination of that might be useful in assessing.
Yeah, of course, there are some overlaps and common commonalities with the
Yeah.
strength and values-based aspects also in CBT and other derived approach from CBT.
Yeah.
Other questions? Oh, yes, Dr. Fava.
Since the term hyperthymia was mentioned, it's we're not discovering anything new. That the term was used by Kraepelin, the hyperthymic personality, and Akiskal made some criteria as a form of soft bipolar disorder. However, it's not what it has very little to do with euthymia. If we look at what Jenny showed, impaired level, excessive level, also the excessive level is very negative and does not pertain to euthymia. And that's the reason why well-being therapy has nothing to do with positive psychology. That's the basic point. But you made me think of a very interesting clinical issue. You see, there was a British psychologist, Neil Johnson, who made some studies on self-esteem in bipolar disorder. Self-esteem is very low in bipolar disorder, also in the up phase. And we did a study on cyclothymic disorder and well-being therapy. And really we had, and Jenny played a major role in that study, we really saw that even in the, let's call hyperthymic phase, true psychological well-being was missing. The person was acting, was doing a lot of things, was saying, was claiming. But then if you try to get beneath the surface, you find a major lacks of psychological well-being. So these were, but these were old literature, okay?
Thank you, Giovanni, for adding this important remark.
It seems like the question is, what is the behavior in the service of? It'd be important to understand.
Any other questions?
Well, I just want to add a few words. Since I'm now part of the staff of the Mass General Brigham, and I'm also director of clinimetric and psychometric studies. If you are interested or just want to more information regarding these clinimetric tools to be used in your studies, to be added, just because they may provide incremental information that you might be interested in, please just let me know and we will try to find a way to collaborate. Since I mean, now it's much easier since I'm officially, part of the team. So that would be my pleasure, and I'm really interested in applying these clinimetric tools across different settings and within clinical populations.
Thank you, Jenny. I look forward to that, and I know you're going to be meeting with Elise Park, and I do think that there are wonderful opportunities that we can share over the time, and that's
Elise was really nice and really open to possibilities. So we're gonna share much more information on
we're very
opportunities.
fortunate to have you part of the department now. It's wonderful.
Thank you so much. I'm very, very happy, I have to say.
And thank you for doing this for us today. So round of applause.
Thank you, everybody, for attending the talk. And I really hope that this will open the door for further collaborations in the future.
We do too. And Darshan, it was recorded, correct?
Yes, it is recording.
Yeah.
Yes.
Okay.
Yes, recorded. Great.
Thank you also for
everyone.
this technical assistance. Okay.
Thank you, everyone. Be well.
Thank you, everyone. Bye-bye.
Bye.
Bye.
Thank you. Goodbye.